All right, we will begin the session with Dr. Deepika Patel, who's going to talk about practical imaging before and after keratoplasty.
Thank you. I've got no financial disclosures. So we've got a wide range of anterior segment imaging devices available to us. And the important thing to remember is that not all technologies are necessarily good for us. So in this talk, I'm going to concentrate on the ones that are good. So I'm going to talk about anterior segment imaging devices that can be used during the surgical journey for corneal transplantation. So we'll start with pre-operatively. So ultrasound biomicroscopy is very handy for looking at the status of the anterior segment behind corneal opacities. And here we've got 3 examples of patients with congenital corneal opacities. And it's very difficult to see what's going on behind there with a slit lamp. However, with UBM, you can see that in the first case, the structures behind the cornea are completely normal. In the second case, you've got lots of iris adhesions. And in the third case, the lens is partially adherent to the cornea. And so having this knowledge aids in planning the surgery. But it's also useful for discussing the prognosis with the patient. Anterior segment OCT is also useful preoperatively, and this is good for assessing the depth of pathology. And so this is a patient with granular corneal dystrophy, and so having knowledge of the depth of pathology can help direct the appropriate surgical intervention. This is a patient who developed stromal haze after a camera inlay, which was subsequently removed. And on the slit lamp, it was quite difficult to assess how deep the haze extended to. However, with OCT, you can see that the haze is maximal at the interface where the inlay had been, and it extends both anteriorly and posteriorly down to the deep stroma. And so this helped to direct the surgeon's management plan. So both these technologies are useful, but they do have different capabilities. So with the UBM, it's great for imaging the ciliary body and through corneal opacities. The problem is that it requires the patient to be supine or, and uses water immersion, although there are newer devices that can get around this. But either way, you still need to have patient cooperation or a general anaesthetic to use it. Anterior segment OCT has the advantages in that it's non-contact and you can image the patient in the sitting position, but it's not very good for imaging the ciliary body and it doesn't give a good view through corneal opacities. In vivo confocal microscopy can be helpful preoperatively when looking at endothelial disease, and so it's useful for differentiating between bullous keratopathy, Fuchs endothelial dystrophy, or ICE syndrome. When we move to intraoperatively, there are 3 microscope integrated OCT devices currently available, and this provides real-time OCT imaging of the anterior segment. So these images can be observed through the surgeon's microscope using a heads-up display or also on an external screen. And the aim of intraoperative OCT was to influence surgical decision-making and also reduce the duration of the surgery. So in anterior lamellar keratoplasties, it can be useful for evaluating the depth of things like the needle and dissection planes, as well as residual stromal depth, and can also detect microperforations. For endothelial transplant, it's useful for evaluating the graft, and one of the things is that it can help verify graft orientation in DMEC, and so that can avoid the need to mark the tissue itself. But how practical and useful is intraoperative OCT? So the Discover study recently looked at this question, and so they prospectively looked at 244 anterior segment surgery cases, and they showed that this technology influenced the surgical decision in over 40% of cases. The images were acquired in real time. That was the main preference of surgeons, and they preferred to view the images on the external screen rather than looking through the microscope. One of the reasons for this is that the image that you see in the heads-up display is not nearly as detailed as what you see on the external screen. One of the other problems is that you do get light scattering and shadowing of the images if you've got metallic surgical instruments in the field. But people are looking at developing OCT-compatible instruments to overcome this. And one of the other big problems is the expense. It is an expensive piece of equipment, and some argue that experienced surgeons can make do without it. The other thing to remember is that we still don't know whether this actually affects the clinical outcomes in the end. The Discover study didn't actually look at that aspect. Post-operatively, anterior segment OCT is useful for looking at endothelial grafts, so you can look at thickness, centration, and then the location and extent if there's a detachment there. And so it can help influence management, looking at things like the need for graft reshaping or repositioning or rebubbling. And this is particularly useful if you've got an edematous cornea and the view is very poor with the slit lamp. You can also use it to look at the graft-host junction in penetrating keratoplasties, and this is important because posterior graft-host malapposition is quite common, and it tends to cause a corneal astigmatism. And so we've got a couple of examples here where you've got malapposition both on the host side and the donor side. And you can also use it to assess the graft-host interface. So this is a patient who had had a DLK and then a few years later had reduced vision, and this was due to recurrence of granular dystrophy at the graft interface. Epithelial ingrowth is a rare complication. Here we've got an example of a patient who had laser-assisted anterior lamellar keratoplasty, and you can see a hyperreflective layer within the stroma. And epithelial ingrowth can also occur after endothelial transplantation as well. And so OCT is useful for looking at the extent of the ingrowth and can also be used for serial monitoring over time. And if you want to confirm the diagnosis of epithelial ingrowth, in vivo confocal microscopy can come in useful. So here we've got some images of showing epithelial cells with areas of fibrosis, and this image was actually taken in the stroma, and so you shouldn't really see epithelium in the stroma. And finally, post-operatively, in vivo confocal microscopy and specular microscopy are both very useful when you're looking at the prognosis and potential for late endothelial graft failure. So there are two long-term studies that have looked at this late endothelial graft failure following full thickness or endothelial transplants. And both showed that preoperative donor endothelial density is actually not predictive. And the important factor for both these procedures is that if you see a low endothelial cell density, and so by that I mean less than 1,200 cells per millimetre squared at the 6-month post-operative time point, those patients are tend to be at greater risk of getting late endothelial graft failure. So this is imaging at 6 months post-operative is useful for giving a prognosis. So in conclusion, I've talked about 5 different imaging technologies, and they can be useful both in making the diagnosis, but also in directing the management and in assessing the prognosis for these patients. Thank you.
Thank you, Deepika.